the web, of course. But this is from the foreword by Gladys Reynolds. We need to ask why these differences exist. We need to be concerned about the data we lack and the quality of the data we do have. We need to reanalyze and reinterpret the data in order to understand the relationship between these disparities and past and current racial discrimination in education, access to jobs, housing and healthcare, and political power. Most importantly, we need to develop prevention and intervention strategies appropriately designed for different cultures. People of different races, ethnic groups, genders, and backgrounds can and should be given active roles in defining themselves and in making the decisions that determine how much and to which groups and to which health area or disease resources are allocated. Very important to remember, we talk about diversity, and we can do that when we have a lot of people from different backgrounds, and it's all true and good and so on. But scientists play very important roles in distributing resources and making consequential decisions on things like what papers get published and where they get published. So a lack of diversity, an underrepresentation of minorities in a profession means that the whole field is being shaped without their full voice. We talk about democracy as government by the people, and we have democracy in giving out money from NIH, and we have it in appropriation in Congress and so on, but it's not democracy that is representative of the population. It is democracy that is representative of subsets of the population. And that's even before you get into the lobbying and things like that. So Ray Greenberg decided, well, I guess it was his decision, I think, to form a committee on minority affairs in the college. And this was part of the idea of the colleges being an important player in minority health. And to do something about the problem, he certainly was genuinely, and his father, Bernie, were genuinely concerned to improve social justice and racial ethnic equality. So he wrote, as president, this was a letter to me asking me if I would serve on this committee. As president of the American College of Epidemiology, I hope that this organization could take a more active role in minority affairs. So we formed the committee. Sherman James was on it, Bill Jenkins was on it, Gladys Reynolds was on it, John Wangu was on it, a number of other people who I have listed in another presentation I've given. And we had our first meeting at the 1991 annual scientific meeting in Atlanta, which was also held the week before the weekend where SAFI was formed. SAFI is the Society for the Analysis of African American Public Health Issues that Bill Jenkins is a founder of, and that was formed that weekend and is now celebrating its 26th anniversary in Atlanta. So if you're going to be in Atlanta at the time of APHA on the Saturday before, it should be a gala celebration. So we met in 1991, and we thought, well, what should we do? How should we proceed? And being epidemiologists, we said, well, we should get some data. And there didn't seem to be any data on the racial ethnic distribution of epidemiologists or of epidemiology students. There was data from the the Association of Schools of Public Health, but it was only for schools of public health, and there were a number of people coming into epidemiology for medicine and so on. So we decided we'll do a survey. So there were, at the time, I was able to identify 66 epidemiology degree programs in schools of public health medicine and veterinary medicine. We did a one-page questionnaire, asked about essentially a census of full-time faculty and students as of April 1992, and came up with these results. So out of 711 total faculty, 2% were black, non-Hispanic, 2% were Hispanic, and in that sample, that census, we didn't have any American Indians. Among the students, there were 2,142 students, 5% were black, 4% were Hispanic, though there's the University of Puerto Rico, they were one of the responding organizations, and they have an epidemiology program. So a lot of those, I think 41 of the 91 Hispanic students were in Puerto Rico. So if you took them out, the rest of the place was not very Latino. And there were 4 American Indian Native Americans. So we made a number of recommendations, of course. Epidemiology's mission should include advancement of minority health and minority epidemiologists. Epidemiologists should be studying minority health problems and solutions, and we should study racism. This was in 1994, I guess, when we published it. Epidemiology programs should be conducting vigorous outreach to make epidemiology careers and financial aid opportunities more visible to minorities. And governments should provide ample, stable funding for minority training and supportive educational environments, plus networks of minority epidemiologists, not just government institutions. Federal programs such as the MARC program, NVRS, the HCOP, should expand their coverage of epidemiology research and training. Those were created primarily for medical scientists. More programs should be created like the CDC's Project Imitep. I don't know how many of you are familiar with Project Imitep, which is now becoming national. Bill Jenkins created Project Imitep when he was at CDC. 6, professional development opportunities should include diversity training related to the review of applications for admission, applications for grants, submitted manuscripts, etc. And a body analogous to the American Association of Medical Colleges Division of Minority Health Education and Prevention should be providing a mandate and resources to monitor progress in increasing the role of underrepresented minorities in epidemiology. And we need to recognize and support and reward epidemiologists who make exceptional contributions to this area. So the article was published along with an editorial that Ray Greenberg wrote. These proposals would make our profession more accessible to a wider range of people, and as a result would build a broader and stronger foundation for the future of epidemiology. And we then made a set of recommendations to the board of directors. The committee discussed what to do, and the recommendations, Sherman James, I came across an email that he sent me back in the 90s. I think this is a very powerful statement. I never imagined in my more than 20 years in epidemiology that I would see such a powerful statement emerging from an epidemiology organization. It will be more than just a little interesting to see the board's reaction. So the first of the recommendations was that the board of directors should formally adopt a statement of principles and goals that recognizes the importance of minority health for public health, the need for racial, ethnic, and cultural diversity in the profession of epidemiology and in the membership of college, including the board of directors itself and all its committees. And then there were another 6, I think it was, recommendations. This was the statement of principles, which was actually adopted and published in the Annals of Epidemiology. The health of all racial and ethnic groups is of critical importance. The profession of epidemiology needs diversity. Educational organizations have a special responsibility. Sponsors of public health should ensure that funding is available. And organizations should work actively to sensitize their constituencies to the issues of racism, sexism, religious favoritism, and homophobia. The statement was signed, the statement was published along with a commentary that was signed by 7 American College of Epidemiology presidents, and it included the statement included a number of action steps. And we went out and got endorsements from the American Heart Association, the American Teachers of Preventive Medicine, the American Public Health Association, the American Statistical Association, Section on Statistics and Epidemiology, Black Caucus of Health Workers, the North American Association, Central Caste Registries, and 12 academic departments of epidemiology. Was UNC one? You've seen that on our website, haven't you? Well, you should see it on the website, because UNC was one. Not the first, though. I think Harvard was the first. I'm going to skip this because I don't want to run too low on time, but you can read it. There's some emails I got from the AAAS, from SPER, and from Helene Yale. So it wasn't just the college, and we didn't lead to this, but Bill Jenkins and Safi were kind of pushing for these things to happen, and Bill gets, I'm sure, some credit for it. So the Healthy People Initiative, the Goals and Objectives for the Nation, planning documents, they secured that for the Healthy People 2010, which was developed during the 90s and promulgated in 2000, or adopted nearly in 2000, had 2 overarching goals, the second of which was to eliminate health disparities. And by the 2021, they needed to have more goals, but they still kept achieve health equity and eliminate disparities. So they got this into national public health policy, which when you consider where things were in the early 80s, this is a huge accomplishment in terms of policy statements. And it wasn't just policy statements. So these are just a sampling. If you search health disparities in the National Academy Press website, I just pulled out 4 covers of some of the reports that have been done during the past, not quite, probably less than 20, about 20 years, I guess. From the national, was the Institute of Medicine, now it's the National Academy of Science, Engineering, and Medicine, on various aspects of health disparities, health equity, community-based research, and so on. So this is getting a lot of attention, and of course, each of these reports is reviewing the literature, so there's an outpouring of literature. Private organizations adopted strategic plans. The American Heart Association, for example, I think the American Cancer Society had one. Various federal and state agencies created offices of minority health. The federal government passed multiple laws, the Congress passed multiple laws, directing the government to set up these offices and programs. All of the NIH institutes formulated strategic plans. The legislation created the Office of Research on Minority Health in NIH, which by later legislation was changed to the National Center for Minority Health Disparities, and then in a later one to the National Institute of Minority Health Disparities, the Affordable Care Act did that. And as one of their reports says, in fiscal year 2001, so that's 16 years ago, NIH spent over $2 billion on research infrastructure, public information, and community outreach efforts to reduce health disparities. So money was flowing. Now, of course, how do you decide whether a particular grant is related to health disparities or not? Obviously, if you're writing this report, you tend to be inclusive, right? And if you're writing about molecular epidemiology, you'll find a lot of things in molecular epidemiology, and if you're writing about whatever it is, so whether it's all disparities research of the sort that you might think, don't know, but a lot of it probably is. But of course, this was just one wave that was going on, and even though it was a powerful wave, other things were going on too. I don't know how many of you heard of the war on drugs, but there was a war on drugs, starting in the late 70s, early 80s, I think it was. 80s probably, with President Reagan. And that put huge numbers of people in prison. And many of them tended to be racial ethnic minorities. So on the one hand, you've got, let's get these folks into epidemiology. On the other hand, you've got, let's get these folks into prison. And so we had this incarceration boom, tremendous growth, and with that came economic opportunity. So you also had the rise of the private for-profit prison industry, which is now a huge part of the incarceration picture. And naturally, they have some interest in keeping the prisoners coming and staying. You had huge changes in technology and automation, which transformed the kind of jobs that were available for many people. And with globalization, technology also gave us the internet and other communications and transportation modalities that enabled large outsourcing of jobs. And we also had a flow of many immigrant low-skilled workers. So you have the Philadelphia story that I was mentioning earlier, and now you have, and not now as much, but had many, many people coming from poor countries to the United States, where even if things weren't great for people without skills, they were a lot better than countries where there were even fewer opportunities. But you had, even for people with skills, you had places like India, for example, developing this huge opportunity to have people in IT and call centers and other kinds of jobs, and now they're able to have them here. Now, I am not saying that should not be. People in India should have every opportunity and right to a fulfilling and productive life as well, and to live outside of poverty. But when you don't manage the availability of jobs, and for various reasons that we don't have time to get into now, we don't, that took away a lot of opportunities that would have otherwise gone to African Americans and Latinos here and American Indians. You have the whole genomics development, which, in the one hand, draws a lot of resources and attention. I remember when you've heard of ECHO, the Center, the Program on Ethnicity, Culture, and Health Outcomes, that Melissa Vines and Paul Godley have led for many years. When ECHO, or its forerunner, was being created, and Bill Roper helped them to get a $300,000 grant from, I think it was Glaxo Wellcome either the foundation or the company. That same year, it was announced that UNC would develop a $40 million genomics building, genomic sciences building. So it just gives you an idea of, yes, we have some resources, but genomics was so much more powerful. It was a 1,000-pound gorilla growing up, because genomics means all sorts of economic opportunities for industry. It means all sorts of career opportunities for people who are going to make names for themselves, and patents and all sorts of things. And it's wonderful, many of the benefits that will flow from that. But it's not really eliminating disparities. And then you have the escalation in educational requirements, which goes on in society. As more people get education, more people need education. Jobs become more technological and so on. People need more education. And at the same time, we've had a cutback over decades in public funding for education. So that increasingly, if you can get money to go to higher education, you'll often have to borrow it. And we don't give you a bargain on the interest. So you now have all these people, young people, and not so young anymore, saddled with major student loan debt. And it's this agonizing decision of, well, do I want to get this degree, or do I want to owe $40,000 for the next 10 years or something like that? So the National Academy, the National Institute of Science, Engineering, and Medicine put together a couple of workshops. This actually was when it was the Institute of Medicine, and reviewed how far have we come in reducing health disparities. And this was in 2010. This was a review of the 2010 Healthy People objectives. So there were these objectives. They were all supposed to be measurable. This was the final review. And you can see here, the top bar shows the disparity decreases for these objectives, the disparity increases for these objectives, and most of them there was no change. So it was essentially a wash, despite the millions of dollars and billions of dollars and all the work and reports and so on. There was no net improvement in health disparities. And for sex, it was not very different. And for education, it was actually substantially worse. If you didn't have education, you were much worse off. And income, it was much, much worse. And geographical status and disability. So race, ethnicity, at least it was a draw. So if you go to the Association of Schools and Programs of Schools and Programs for Public Health, this is from their website, now 32 years after Heckler. Despite great strides in the advancement of public health, health disparities still exist, and as I say, it's similar. And this I came across in The Guardian, the scientific references there too, about hookworm in Lowndes County, Alabama. Lowndes County may be familiar to you as one of the places that became notorious during the civil rights movement, Martin Luther King. And hookworm apparently is rampant. Hookworm was rampant in the South. I mean, that was the public health problem in the South. And one of those great achievements was the elimination of hookworm. And it turns out that it's still around. And you know what's responsible for that? Probably poor sanitation, that they don't have public sanitation. People are using septic tanks and so on, and they're not being able to maintain them. And the cost of getting public sewage is too much. And essentially, things spread. So, can we make epidemiology great again? I've read Thomas Kuhn's The Structure of Scientific Revolutions, and I can't summarize it. I couldn't encapsulate it, so I actually quoted from The Guardian. Thomas Kuhn, who was a physicist and became an historian of science, talks about how science progresses, and that although there's what he calls normal science, where people work within prevailing theoretical paradigms and make small discoveries that refine the understanding of knowledge, and great progress. This is not a criticism. However, every so often, the observations don't fit into the prevailing paradigm, and there's a resistance to changing because the paradigm has served so well. But nevertheless, these instances build up, and at a certain point, there's a crisis in the field. and a new paradigm emerges. And he describes this very eloquently with examples, mostly from physics, but other fields a bit as well, of how that changes. And it's not necessarily through force of argument. It's often that the younger people didn't grow up attached to the older paradigm and they're ready to accept it. So in epidemiology, we have a risk factor paradigm that we have grown up with and that has brought this huge explosion of knowledge and advances. On the other hand, there's some things that just aren't quite working with it and don't really there's a problem with it that we haven't quite put our hands on it. But we may need a new paradigm, and of course, it takes a while to come. We don't know when it comes because the people who advance it are often dismissed or not listened to and so on. But I just wanted to put that out there. When you have some leisure time, this is a very interesting book to read. And our own Carl Schei, who was a faculty member here when I when I came to the department in the 70s, and served as chair in the 90s for several years, published an article in 1997 about the failure of academic epidemiology, witness for the prosecution. As a basic science of public health, epidemiology should attempt to understand health and disease from a community and ecologic perspective. As a consequence of how society is organized and behaves, what impact social and economic forces have on disease incidence rates, and what community actions will be effective in altering incidence rates. Epidemiology must cross the boundaries of other population sciences and add to its scope a macroepidemiology, a study of causes from a truly population perspective, considering health and disease within the context of the total human environment. So he was, I think, retired then, or just about to retire. And when you get to retire, if you have had a good career and you have a good retirement income, you will